So welcome everybody to the MPN Voice Patients Forum, virtually coming to you from Manchester. As I talk, I'm sitting in a semi-detached house in North London, and the weather is appalling, so it makes me feel like I am actually in Manchester. So,
how rude! How rude! I'm sorry.
Yeah.
The weather's been beautiful in Manchester for the last few weeks.
While we're waiting for Jon to come back, we would like to say thank you for joining us this afternoon. I'm Maz at MPN Voice, and you can see my colleague Marilyn there. She'd like to give a wave, Marilyn. We're just waiting for Jon, our co-chair, who is going to be introducing the forum for us this afternoon, if we do get him back. And we have got an exciting forum for you with the team from Manchester, which is very kind of them to support us again. And we will see what we can do. I don't know what's happened to Jon.
Yep.
Thank you. Well, welcome once again, everybody, to the MPN Voice Patients Forum coming from Manchester today. We're very excited to see you all here. It's very kind of you to join us. MPN Voice, who are we and what do we do? MPD support was formed in 2003 by a very small group of patients and haematologists and specialist nurses and psychologists who got together because they discovered for MPN patients that there really wasn't a lot of information available. We became MPN Voice in 2013, and we are under the auspices of Guy's and St Thomas's Hospitals in London. You have the next slide, please, Danny. Okay, we need to go through some housekeeping with everybody. If you could submit your questions to the chat panel, we have a question and answer session at 5:10. That will be a live session where the team will be answering the questions. We have already had some pre-submitted questions from the audience, and the team will be going through those. Please don't ask any questions on the chat panel that are completely just to do with your blood counts, etc. Please don't put anything like that. We can't answer those questions. We can only answer them generally. And if everybody could please remain on mute during the talks, we would be very much obliged. And a feedback survey at the end of the forum. We would really appreciate it if you could fill out the feedback survey, because we want to know what we're doing right, and we also want to know what we're doing wrong, so that we can make changes to improve the forums for everybody. So it really does help us if you could fill those in. It'll only take you a few minutes, but we do appreciate it. Thank you very much. This is the agenda. Hopefully you've all had a quick look. We've got some brilliant talks. So we've got ET from Dr Rachel Brown. We've got a lovely patient talk from Louise. Dr Rowena Thomas-Dewing is going to talk about polycythemia vera, and Professor Tim Somervaille is going to talk to us about MF. Then we have the panel Q&A, and then we're going into the breakout groups where we will all be split up into the separate groups for ET, MF and PV, so that we can all have a little chat about those different MPNs in smaller groups. Thank you. So can we move on? As I've already explained, we are MPN Voice, and we are registered under the auspices of Guy's and St Thomas's Hospitals in London. And we're very grateful to be part of such an amazing charity. They look after us very well. We work very closely with them, particularly with the fundraising teams. And our medical lead are also based at Guy's Hospital, as many of you know. We have the amazing Professor Harrison looking after us all. And we also have committees, next slide please, Danny, who run MPN Voice. So we have an executive committee. We have co-chairs of Jon Mathias, who we've lost this afternoon, unfortunately, and Nona Baker. We have Tim Ellis, who looks after all of our finances, and we have Professor Harrison, who is our medical director. Under those, we have a management committee, and then a separate fundraising committee and a clinical advisory committee. As you can see, we have quite a number of excellent doctors on there from around the country. They're based around the UK, and we have a couple of excellent specialist nurses as well. So they are looking after us and advise us on lots of things. We go to them particularly for all of the COVID information that we've been putting out throughout the year. They've been helping to provide a lot of that information and to answer a lot of the questions that patients have been putting forward to us. So we're extremely grateful to all of them. They've been very, very busy throughout the year, as you can all imagine, but they have still given time to the MPN Voice community. So we're very, very grateful to them. Next slide, please. And going on to coronavirus, it's been an awful year for everybody. And during that time, we have tried to keep up to date as much as we can with giving information to the MPN community about coronavirus. It's been worrying everybody. We understand that it's been very, very tough for people with MPNs, but we're coming through it, and we hope that you have found that the information on our website has been helping you. We've also been conducting surveys throughout the COVID pandemic to ask you, the patients, lots of different things, and we are hoping that this is leading to give us lots of answers about all things COVID. We don't know all of the answers, so thank you to everybody that has been completing all of the surveys. We do much appreciate your support. Other information that we provide, next slide please, Danny, is through our website, which we hope you've all had a look at, and our patient information booklets. You can see the little pictures of them there. We supply those to the MPN community and patients alike. Hopefully they will have them in your hospital department. If they don't, ask your nurse if they can order them. We also have a presence on Facebook, Twitter, and we have a YouTube channel where you can find lots of videos of all our forums, and the video of this forum will be available on there hopefully by the end of the week. And other support, next slide please, Danny, is through our regional patients forums. As you can see, we go around the country every year to various locations, and we're supported by some excellent teams, as we are today with the team from Manchester. And you can see the numbers there. We're supported extremely well by the MPN community, so we always love to see people at the forums. It's a great way of getting to know everybody, and we do hope that we will be back early next year to the face-to-face forums. We are planning to get back on the road, but in the meantime, until then, we will be continuing with the virtual forums. We will be announcing some more forums coming very soon, so do look out on the website and look out for our emails. If you could do the next slide, please, Danny. Thank you. The virtual forums, we've been doing them since last year because we had to change the way that we were working, and we wanted to keep everybody involved in the community. And as you can see, it has the advantage that we can include people from across the world, which has been absolutely amazing. And as I've already said, the videos are available on the YouTube channel, and they have been viewed a total of well over 12,000 times so far. So if you haven't had a look, go and have a look. They're amazing. Next slide, please, Danny. Research. MPN Voice is very much into supporting research, particularly to find out why we have MPNs. We don't know. We all want to know. We have MPNs. All of us that are involved with MPN Voice have an MPN ourselves. So we want to know as much as you do. And it's very important for us that we do continue supporting research. We've got some amazing research going on at the moment. We've got the Mascot MPN SVT registry that we are helping to fund, the Tamarin using tamoxifen, the landmark surveys, which came out a couple of years ago, found out lots of amazing stuff about MPNs and symptom burden, quality of life. And Landmark 2 is currently underway, and a lot of you I know have completed the landmark survey 2 already. So thank you to all of you who have done that. We very much appreciate your support. If we could go on, please. Sorry, I am going to have to hurry through the next few slides. I'm aware of time. Mithridate is an ongoing study. There's probably many of you watching this afternoon that have signed up for the Mithridate study. And again, thank you very much. Let's hope that it does produce some excellent results. Next slide, please. Mosaic study. You've probably heard us talking about Mosaic quite a lot. It's been going on for a number of years now, and MPN Voice has been supporting it right from the very beginning. It is trying to find out why we have MPNs, and hopefully it will lead to one day finding a cure. Again, it has given us lots of excellent results so far, and we very much appreciate everybody supporting it. The fundraising team are always pushing people to fundraise for Mosaic study. So those of you that have and will be in the future, again, thank you very much indeed. If we could go on to the next slide. Again, coronavirus, a major piece of research is the vaccination study that is being run by Professor Harrison and her team at Guy's Hospital. We did advertise it about a month or so ago. It's signing people up to look at the response to the COVID infections and the vaccinations just for people with MPNs. We don't have much data to release at the moment, but as soon as we do, we will get that out to the MPN community. But hopefully it will be very exciting news for us all that have had the vaccines. Next slide, please. Advocacy. Advocacy is Jon's baby. He's got us very involved with advocacy in the last few years, and we are part of the MPN Advocacy Network, which is an international network of patient organisations who support people with MPNs. And through that, we hope to give patients more of a voice within their community, to government bodies and to pharmaceutical companies and to the MPN community themselves. So that is something that we are very heavily involved in as well in MPN Voice. Next slide, please. Fundraising, donations and grants. We couldn't exist without people fundraising for us and getting donations and grants. We're always very, very grateful to every one of you that fundraise for us, that make a donation. It's excellent. And it does keep us running, and we do have to apply for grants from companies wherever we can as well. But what do we use the funds for? Well, we fund research projects, as we've already said, patients forums like today, running our website, printed materials, and supporting you, the MPN community, like this, and via Health Unlocked and Facebook and Twitter. And we also support the MPN healthcare communities as well. So if you do want to do some fundraising, if we could have the next slide, please, so that we can see some of our excellent fundraisers. There are lots of ways that you can get involved. You don't have to run a marathon. You don't have to jump off the side of a tall building. There are many ways that you can fundraise for us. So if you would like more information, please get in touch with either myself or Marilyn. The fundraising team are here to help and support you, and we can give you lots and lots of ideas and ways that you can help. And these are some of our fundraisers that have been doing some excellent events for us during last year and this year. So thank you again to all of you. Next slide, please. As we've already said, donations, please. We do rely very much on the donations that we receive from you, the community. If you feel that you can support us in any way at all, please do. You can donate via our website. You can do it with your credit card, debit card, or you can do it over the telephone. If you do want any more information, please get in touch. Just email us at info@mpnvoice.org.uk and we can help you with that. So now I would like to say thank you to the team that are supporting us this afternoon. We have Dr. Rachel Brown from the Manchester Royal Infirmary. We have Louise Broughton, who is giving us a patient talk. We have Dr. Rowena Thomas-Dewing from Salford Royal and Professor Tim Somervaille from the Christie NHS Foundation Trust. So I would now like to pass you over to Dr. Rachel Brown, who will be giving her talk about essential thrombocythemia. Thank you.
Thank you, Maz. So let's just see if the technology won't let us down and I can share my slides. So good afternoon, everyone. So I've got the first talk and I'll try and keep to time. So please forgive me if you feel that this is a little bit brief. It's always tricky to kind of aim these talks, as some of you will be experts in this condition and others of you will be just starting on your ET journey and your MPN journey. So I've tried to kind of aim for the middle, but we can always talk about other things in more detail in the Q&A session and also in the breakout groups. So as I've got the first talk, I thought I'd just briefly explain what myeloproliferative neoplasms mean for those of you who don't have a GCSE in Latin. So myeloproliferative neoplasms is the new term. It's been around for a few years now for what we used to call myeloproliferative disorders. All we mean by that is that it's a myeloproliferative. So myelo is Latin for bone marrow. Proliferative just means that we're making lots of cells. And then when ET and polycythemia were kind of in the kind of blood cancer bracket, although we'll talk more about that in a little bit, we changed from diseases to neoplasms. And essentially this, all it means is that our bone marrow in ET and polycythemia are making too many of the cells in question.
Hi Rachel, sorry, could you just unmute?
Yeah, thank you. It's like gremlins are in the machine, I think, this afternoon. So the cell of origin is in the bone marrow itself. So let's see if I can, yeah. So there are lots of different types of MPNs. The most common are ET, polycythemia and myelofibrosis, but there are other things in common with other disorders that you may have met patients with or see online. But we're talking about ET first of all. So platelets are made in the bone marrow, as I've already mentioned. So basically what normally happens is that our liver makes a hormone called thrombopoietin, or TPO, and that is absorbed by platelets. The idea being that if you don't have enough platelets, this hormone TPO will then get to the bone marrow and will tell the bone marrow, we need more platelets, start working a bit quicker. If there are lots of platelets, the TPO doesn't make its way to the bone marrow, so you have a stable platelet count. A normal platelet count, certainly in my lab, is around 150 to 450. You might see some slight variations in what the normal is at your lab, depending on the average of their patients. The cell in question in the bone marrow that makes platelets is this beautiful cell called a megakaryocyte, or megas for short, and they make our platelets. In ET, the bone marrow stops listening to that TPO. It ignores it. Whether or not TPO is present, it still makes platelets. And that's because of a mutation in the proteins that control growth and development. So there are 3 mutations that you may have heard of. JAK2, which about 50% of patients with ET have. CALR, which just under a quarter of patients will have. And MIPL, which about 5% of patients will have. And anyone who's heard my talks before will know that I giggle every time I say the word MIPL, because it sounds like nipple, because I am essentially a child in an adult's body. But MPL if you are going to be a professional. So some patients with ET will not have one of those identifiable mutations, but the majority of patients do. And as we go through the talks, you will see that they all have things in keeping, particularly the JAK2 mutation with the other conditions we're talking about today. So this is a megakaryocyte, and this is the receptor that TPO binds to. And if you have a mutation in JAK2 or MPL, you affect the actual receptor, and CALR affects the way the receptor talks to the cell, sorry. So this receptor, which would normally only be switched on when TPO binds to it, ignores everything and just carries on making cells. This is a picture of a megakaryocyte from a company that makes teddies of cells, and I have them all in my office to keep me company. So again, essential thrombocythemia or thrombocytosis, often the definitions are interchangeable, but ET for short. So essential just means that it's a primary problem with the platelets, so it's an issue coming from the bone marrow. Thrombocyte is the American for platelets, and also comes from the Latin. So thrombocythemia or thrombocytosis just means too many platelets. And the end result is that our blood gets too sticky if you have too many platelets, and that therefore you increase the risk of blood clots and things. This is quite a rare condition, as I'm sure you will have noticed, you know, from a group in Manchester, although I know we've got a few from other areas of the world, but it occurs in about 2 in 100,000 patients, with around 24 in 100,000 having the disease at any one time. So most haematologists in most centres will have a few patients with this condition at least. Generally, it affects patients over the age of 60. But about a fifth of patients will be diagnosed earlier on. And sadly, women are slightly more likely to develop the condition than men. So how's it picked up? Well, I'm sure some of you will just have been found because you had a blood test with the GP or at the hospital, and they found that the platelets were slightly raised, and you went on to have investigations. Sadly, some patients present when they've had a blood clot or have had a stroke and are found to have high platelets then. Rarely, some patients can have bleeding or bruising symptoms, often if the platelets are very high. Some patients can get symptoms. That might be the reason why they went to the GP, but often it's actually just things that we pick up when we have a chat in clinic and are talking through the signs and symptoms of the disease. So the platelets can cause sluggish blood flow in the smaller blood vessels. So patients can develop headaches, they can feel dizzy. Sometimes patients say they just feel a bit muggy headed, they don't feel as sharp as they did before. Some people can have patients with their vision, and some patients can complain of burning red or cold hands. And some patients will be picked up if they're either struggling to get pregnant or have had miscarriages. So the diagnosis. So normally we actually only need blood tests for ET to actually make the diagnosis. We need a high platelet count that's been there for a couple of occasions, and we need to rule out reactive causes. So iron deficiency can very commonly cause a high platelet count, so that needs to be ruled out. We can then do our fancy mutation tests for JAK2, CALR and MPL on blood tests. I'm sure you'll remember it takes a few bottles to get the diagnosis. And we can prove that there is a clonal bone marrow problem. So we can find that mutation is present in enough cells to be causing a problem. If those are negative, then that's when we definitively need to do a bone marrow test in ET, so we can find the diagnosis based on the way the bone marrow looks. And this is a solid bit of someone's bone marrow, the bone marrow biopsy, for those of you who've lucky enough to had one done. And the megakaryocytes cuddle. I work in the lab a lot, and I always tell my trainees that megakaryocytes should never cuddle. They should be socially distanced. These are cuddling, and their nucleuses look quite erratic and unusual. So it's quite a good diagnosis to make just looking down the microscope. I think one of the questions that we got through from when you signed up for this, someone said, do you have to have a bone marrow at diagnosis? And pathologists often would say, absolutely, we always need a bone marrow because that's the only way you can definitively tell ET, but they're not the ones doing it, and they're certainly not the ones having the bone marrow, which isn't horrible, but it's not the most fun you can have on a Wednesday afternoon. So some doctors will like to do it, and I would do it if there was any kind of something that was a little bit unusual about the presentation. For example, if you were anemic but had a high platelet count, or perhaps if you had a high white cell count with a high platelet count, because that's not typical for an ET patient. ET patients should just have a high platelet count. And there are a few other reasons why you may want to do one. So treatment. So this is the treatment pathway from the British Society of Haematology, which has been present. It's quite an not old guideline, but it's been around since 2010. Written by our Queen, Professor Harrison, and other consultants around the UK. And yes, you could say, well, it's a bit out of date now, isn't it? It's 11 years old, but actually, it was based on really good evidence, and what this says is still very, very relevant to treatment. So every patient with ET really should be considered for an aspirin or another antiplatelet agent, unless you're already on an anticoagulation agent such as warfarin or apixaban. And that helps to thin the blood and stop the platelets from being too sticky. There's some evidence coming out that if you're very low risk of blood clots, so you're under the age of 40 and have no other risk factors, and you have the CALR mutation, then perhaps you don't need an aspirin. I don't practice that in clinic myself because it's not in the British guidance. But if a patient was really struggling with aspirin and getting lots of symptoms, we might discuss the risks and benefits. But certainly, if you're a JAK2 mutation or over 40, aspirin or clopidogrel is a really good drug to help make those platelets less sticky. And evidence has shown that it works really well. So as I've kind of already mentioned, we risk stratify patients quite a lot with this condition. We base treatment we give you on your risk factors. And when we're talking about risk factors, in this case, we're talking about your blood clot risk from both venous, so deep vein thrombosis or blood clots on the lungs, and arterial, heart attacks and strokes, all the things that we really don't want to happen to you. So currently, anyone over the age of 60 or has a very high platelet count or has had previous problems with blood clots would definitely be high risk. If you're less than 40 and don't have any problems with blood clots or any risk factors for heart attacks and strokes, then you'd be low risk. Otherwise, you can often be a bit in the middle. And at the time when this guidance was written, we didn't have a lot of evidence, but we now have the results of some trials, which suggests that basically if you're under 60 and don't have a lot of risk factors, you're fine to just have an aspirin. Over 60 or on the other high risk features, then we need to cytoreduct you, or we give you other treatments to get that platelet count down to a normal level, ideally less than 400 wherever possible. There are lots of different treatments. Hydroxycarbamide is often the common one used first line, and that's because hydroxycarbamide has been around for a very long time. It can have some side effects, but thankfully they're quite rare, and it doesn't interact with a lot of other tablets, so can be quite helpful. Other options are things like interferon, which is often our first line in younger people because hydroxycarbamide isn't safe for women who want to get pregnant. It's not safe in pregnancy routinely, although again, there may be times when ladies are allowed to, well, not allowed, it's our own bodies, isn't it? But some women may stay on hydroxycarbamide when pregnant if the doctors feel that that's the most appropriate thing for them. But generally, we'd use something different like interferon. Patients with ET do have slightly higher risks of complications in pregnancy, so preeclampsia, miscarriages, sadly, but we have quite a lot of experience of managing patients through pregnancy with ET with very successful outcomes. And I've got lots of ladies who've had babies, and when COVID's over, I can't wait for them to start coming back and visiting me in clinic again. And then we want to manage your other risk factors. So this is the thing that you can do. You can take control of your own health in some ways with ET. So staying nice and fit and healthy and reducing your risks of heart attacks and strokes. So not smoking. If you're diabetic, managing your diabetes levels, keeping your cholesterol down, keep exercising, because that all reduces the risks for us. There are other medications we can use to control the counts, but I have to say they're used less and less frequently now. But MPN Voice does have some really good information about them. As I say, the intermediate group, so our patients between 40 and 60, there's now good evidence that you don't need cytoreductive treatments unless you've got a lot of risk factors for heart attacks or strokes. So for example, if your dad had a heart attack, sadly at quite a young age, you had a high cholesterol and high blood pressure or was diabetic, then I might be having a chat with you about starting treatment a little bit earlier. But again, individualized approach, but also a discussion between me as the doctor, my specialist nurse, and you as the patient with your family. Very briefly, because I know I'm running out of time, patients often ask about HRT or kind of contraception. So estrogen is the thing in contraception and HRT which increases your risk of blood clots. So we would generally advise not to have estrogen containing treatments. But progesterone only are absolutely fine as both the contraceptive pill or injections, and also progesterone only HRT or topical HRT. So your patches, your creams, things like that are absolutely fine. And again, it's a risk benefit. So if you've got absolutely horrendous menopause symptoms that's really affecting your quality of life, then it's worth talking about with your doctor and specialist nurse to make sure that we're providing that individualized approach. Surgery, I would make sure that you speak to your team. We generally don't stop your kind of hydroxycarbamide or interferon unless we absolutely have to, but normally aspirin needs to be stopped. But just ask us and we'll give you appropriate advice. I think we have some better slides than this to talk about later with COVID, so we'll talk about that later. Prognosis. So if you're treated appropriately, then the prognosis is absolutely, well, excellent. Having ET doesn't shorten your lifespan, and the real risk with ET is blood clots. There is a very small chance of progressing to myelofibrosis, as Professor Somervaille will talk about later, or leukemia. But that's a very, very small chance, and that's why you're followed up by a haematology team that's really specialised and is really used to looking at blood counts to look out for any problems. Maz has talked a lot about research, but that's always the thing that a lot of people on these webinars and meetings like to know about. So Maz has mentioned the Tamarind study, which looked at tamoxifen. A lot of you have asked questions about interferon, especially the newer interferons, Besremi is its brand name, and whether that can actually reduce the amount of JAK2 in a patient's body, which may prevent kind of progression to leukemia, or actually might put the disease into what we would call a remission, where you might not need treatment for a little while. There's only a few studies on that. It's still quite early data, and a lot of the trials have been done by the drug company. So it does need to be taken, as a wider picture, but there's a lot of promise with that. There are some interesting phase 1 trials going on, which means that they're very early. So we're not looking at any of these medications being available to patients for many, many years. But our international European conference this week, there's been a couple of drugs mentioned that might be suitable for ET to reduce that platelet count down with, in the early studies, very few side effects. And interestingly, our British teams have been looking at when do patients with ET and polycythemia actually acquire the JAK2 mutation. And it looks like the JAK2 might actually be kind of acquired, for want of a better word, in patients very early on in life. So when they did small studies and they looked at patients in great detail in very clever tests, they found that most of the patients had got the mutation by the time they were under 14 or 15 years of age. That JAK2 mutation stays stable for many years, and then there's probably something else which kicks it to become slightly more cells with the JAK2 mutation that then can cause problems with patients. And by getting information like that, although it sounds quite scientific, that's going to give us real help at identifying other treatments that could be potentially really helpful. And that is me. Thank you very much for your attention, although I can't see anyone, so you could all have gone off for a cup of tea, but we'll do questions at the end. Thank you.
I think we're coming to Rowena for the next talk. Jon, take it away.
Oh, I'm sorry. I had a few technical issues earlier. I'm really sorry about that. But I gather that Maz did an amazing job of doing the introduction. So thank you very, very much, Rachel. Louise, if you're ready, you're up next for your talk about your PV journey.
Just unmute myself. Can you hear me, everybody?
Yeah, that's great, Louise.
Great. Okay. Hi, I'm Louise. I'm 67 and I live in Cumbria. And I was diagnosed with PV about 13 years ago. So I'm going to talk quite quickly because there's a lot I want to fit in. And please don't think I'm preaching or telling you what to do, because everything that I talk about, I might say you and not me. It means that I've actually experienced it and how I've coped with symptoms, etc., etc. And I thought it might be a bit more straightforward if I split my little talk into sections. So I'm going to talk about diagnosis and who to talk about with it. Then 2, choosing and talking to your haematologist. 3, changing a lifestyle. 4, symptoms and how to live with them. And 5, the future. So my diagnosis and who I told, I think I probably had PV or started with PV. I felt as I did probably 7 years before. Had no idea, of course, at that time, because I had all sorts of weird symptoms, headaches and neck ache and lack of concentration, bone ache, I had a face like a ripe tomato, visual impairment, insomnia, the lot. GP couldn't, of course, find anything wrong with me, never thought to do a blood test until I started the dreaded itch, which I'll talk about in a minute. But I was lucky enough, to have had hepatitis A about 20 years before, which came along with the same itch, pruritus. And I just thought, I wonder if I've got something wrong with my blood. So I actually booked a full blood count test with my GP. And about 3 weeks later, they told me I had PV. So I was assigned to a very, very good haematologist who certainly knew what he was doing, but his bedside manner wasn't quite what it could have been. It was sort of, you know, hello, nice to meet you. You've got polycythemia. The prognosis is about 10 years, and this is what we can do for you. So it was all a bit of a shock, quite frankly. And I called him Dr. Gloom. So I was with Dr. Gloom for about 4 years. And was I frightened? Absolutely. Was I depressed? Absolutely. Yeah, of course I was. I had nobody to talk to. I didn't know about MPN Voice. It was 2009. None of the guys I saw, the nurses or the haematologist I saw, knew about MPN Voice. So I missed out on that in the beginning. And eventually I thought, this is ridiculous. This will not do. I'm not going to live my life worrying about this disease or this cancer. So I gave myself a jolly good talking to. And I said, come on, get a grip, woman. So I went to Dr. Google and I sifted through all the rubbish that is on Google and finally found MPN Voice. And I learned as much as I could about this condition that I'd been diagnosed with. And I emailed close family and friends, including our adult children. Why did I email? Because I think if you tell people over the phone or face to face, they will only take on board the word blood cancer, and before you know it, they'll have you choosing a spot in the cemetery and you'll be dead and buried, or they'll think you have leukemia or something. So really important, I think, to put things down. If anybody's been newly diagnosed, put things down in writing for people so they know what you've got. I'd occasionally feel, grotty, as we all do. So I said to everybody, look, occasionally I might get a bit ratty, I might be tired, I might need some help. Fortunately, I've got a super husband who steps in to do things and seems to be intuitive when I'm not feeling quite right. Long suffering, poor man, he's wonderful. As treatment progressed, obviously the symptoms lessened, and I was left with various bits of symptoms. But I decided earlier on that life could be a heck of a lot worse. If I had to have a cancer, this actually wasn't such a bad one to have. It's treatable, but it's not curable. So choosing and talking to my haematologist, you know, as I said, I stuck with Dr. Gloom for around 4 years, but we can all choose our haematologist. We are in charge of our own bodies and our own lives. And I decided that as time went on, I didn't want to be treated. Once my blood results were absolutely fine, I was palmed off, if you like, or put in the care of approximately 7 locum haematologists in 10 months. And I don't honestly think that they really had a handle on PV. I think I really knew more about what was happening in my body than they did, because there are loads of blood cancers and not everybody can be expected to be, you know, up there with every one of them. So I think I was very lucky to have avoided a stroke in the beginning, but I was left with insomnia, the dreaded itch that I'll talk about in a minute, the odd headache, and of course, fatigue. So symptoms for me, the worst one in the first 12 months was the itch or pruritus. Now, I know that all the medics listening at the moment are very, very sympathetic to acrogenic pruritus, but if there are any family and friends or nurses or anybody who might not be too familiar with it, it's more than an itch, folks. It's like having thrush under your skin, a blowtorch on the top, and about 1 million insects biting you at once. It's really the most unpleasant. It's purgatory, actually. And I'm a hardy old bag, as you'll gather, but it reduced me to the foulest language on earth, and tears on many occasions. So I put up with it for a year, and I thought, I'm not doing this anymore. I'm going to find out what I can do to stop. And of course, if the proper aquagenic pruritus, of course, is sparked off by showering and bathing. So I stopped showering and bathing and swimming and all contact with water, apart from neck upwards and mid-calf downwards. And I haven't had a bath or a shower or been swimming for 11 years now, as Maz and Tim knows. And we had a bidet installed. And if you do want to go down this route, but you haven't got room for a bidet, you can actually buy plastic bidets online from Amazon. They're about £8. You can fill them up under the tap and sit them on the loo and bob to your uncle and away you go. So yeah, I don't think I pong. I mean, I manage underarms and feet and nether regions, and I wash my hair over the bath. And quite honestly, I've never looked back. But I am really careful when it comes to air conditioning, because that can spark it off sometimes. I've got air conditioning on my legs. I never wear tights. You will always see me wearing trousers so that I don't have a draft on my legs. And I'm careful with what I eat. I don't drink alcohol, I don't drink caffeine, and I don't drink decaf stuff. So that's how I've tackled aquagenic pruritus. Don't sit on it. And if you're family and friends, please take this terribly seriously, because it really is a dreadful condition. Fatigue. So I'm lucky, most of the time I escape fatigue. For me, a bit of heavy gardening, I'm okay with a bit of weeding, but if I'm digging or lots of housework, if I do more than a couple of hours at a time, or just little things will spark it off, and then I plonk down in the chair and have a sit or a snooze if I'm really feeling tired. And then I think, right, it's time to go out for a walk, because walking is one of the things that I think can actually budge fatigue big time, because it gets your circulation going. It raises endorphins, the feel-good hormones, and does it lower blood pressure? I don't know, it's supposed to, but it works for me. And I walk now between 1.5 hours and 2 hours every day. I think this thing on the internet, or what everybody's saying about 45 minutes a week, I don't think that's long enough, certainly not for us. I think we need at least an hour a day, as briskly as you can. I go uphill. We've got a hill behind the house called Arnside Knot, and I drag myself up there every day with the dog. And I come home and I feel much, much better. Certainly if you've got a headache, that seems to go if I'm walking. So that works for me. So just to summarise, really, I haven't got a clock. I have no idea how long I've been talking, so I hope I haven't overrun. But, you know, to summarise, if you are newly diagnosed, it's okay, really okay, to feel frightened and depressed, but don't sit on it. Please share it. Get a second opinion. If you're not happy with your haematologist, then get a second opinion. Contact Maz for a buddy. I've buddied around, I think, 38 newly diagnosed patients. And you know, we're not doctors, the people who do buddying, but by golly, we can offer crumbs of comfort, half loaves of comfort actually, and lots of sympathy. And you know, I think that really helps. And some of the ladies I've buddied, they're all ladies actually, we've become friends. Others I talked to maybe a couple of times and I never hear from them again. So you know, some people need constant buddying, and the majority just go away and they get their head around it. And I think it takes you about 2 years to get your head around your particular problem. Certainly took me 2 years, and we're not allowed to be buddies until we've had the problem for 2 years. And then suddenly, I think, shall I use the word comfortable? I think you sort of become comfortable with it. You get your head around it, you learn about it, and you become comfortable with your condition, because we can all live really, really well with this. If our cups are 3/4 full and we think, this is not going to get the better of me. Yeah, I've got flaky skin and I get the odd ulcer in my mouth and my hair's going a bit thin and I haven't got a hair left on my body, but you know, what the heck? As long as I feel well, then that suits me. Where am I? Keep your cup 3/4 full. Don't be afraid to ask for help and support. Diet. Now then, I studied dietetics and nutrition about 50 years ago. Never practiced because I followed my husband around, but I'm a great one for healthy lifestyle, really, really healthy lifestyle. When it comes to food, I eat probably 70% plants, fruit, salads, vegetables, all that sort of stuff. 15% protein and 15% carbs. I'm not a vegetarian. I don't eat low fat stuff. Everything I eat is full fat. But I do believe that our diets can help us an awful lot. And we are definitely what we eat. Do I eat organic food? Yes, I do, if I can get it. I shop in Sainsbury's and they have a good range of organic food, because I thought, you know, when I was first diagnosed, I thought, well, I'm going to be piling my body with chemicals in the form of hydroxycarbamide, aspirin, levothyroxine, which I take a small dose of now. And I also take quite a lot of antihistamines for another condition not related to this. So I just thought, right, I'm going to go down the organic route. I'm not, you know, a sandal wearing lunatic who bays to the moon, but I do honestly think that we need to be very careful with what we put in our bodies. And I certainly feel a whole lot better for it. And I drink between 2 and 2.5 litres of water every 24 hours, not in 8 hours or 6 hours. I space it out, and I drink through the night, which means, of course, lots of trips to the loo, but I'd rather do that and feel better and well hydrated. And that's just about it, really. You know, the future is incredibly bright for us all. It really is. There's so much research going on. And on that, I'd just like to ride on the back of what Maz was saying for fundraising, because it's so important. There are almost 3,000, I think, signed up members. I hope that's right, John. And if everybody just gave 20 quid a year, or everybody else who might be listening to this on YouTube out there, please donate, because it's all in our interest for the forums and everything else, the information. And it's so important that we keep the money coming in, you know. So have your friends around for a coffee and charge them a tenner or whatever you want to do. And the last thing is, I just wanted to say, Tim, a really public thank you to you and your team. I know you'll be sitting there cringing, and I'm so sorry. But, you know, you do work relentlessly on behalf of all your blood cancer patients. And I've spoken to people in the waiting room who are sitting there clutching their spreadsheets, who go in and wanting to know all the results and discuss all the results. You know, don't do that. It raises your stress. It raises the burden on our haematologists, who are so busy. You have to trust your haematologist, honestly. And I mean, you don't go out and have your car serviced, do you? And then come home and lift up the bonnet and go over everything that the mechanics do. Well, I don't anyway, you might, but I certainly don't. So I really trust the guys who are looking after me. And you should too. Just find the right person and you'll be fine. So thanks, Tim. I really appreciate everything you do, and I know everybody else does as well. And if you now have another 200 patients beating up past your door because of everything I've said, I'm so sorry. But anyway, thanks very much, and thanks for listening, everybody. Bye.
Thank you, Louise. That was fantastic. I think a lot of people, when they come to these forums, whether we're doing them face-to-face or online, they obviously get a lot from the talks from the doctors, but I think it's the patient voice that really makes a difference to a lot of people. And I thought that was a really good kind of picture of what it's like to live with an MPN. And obviously I can relate to a lot of what you said, but thanks again. I thought that was brilliant. I'm sure you'll have quite a few questions coming your way. Okay, so next up is Dr. Thomas-Dewing from Salford Royal Hospital, and she's going to talk to us about polycythemia vera, coincidentally. So over to you, Rowena.
Thank you, John. I'm just going to try sharing screen. Let's hope it works.
Yeah, if you just go into presentation mode, Rowena.
Is that all right?
Perfect, that looks great.
Lovely. So I'm Rowena Thomas-Dewing, and I'm one of the haematology consultants at Salford Royal Hospital. Just to say first, that was an excellent talk, Louise, so that'd be a hard act to follow now with PV. And there is going to be some repetition with Dr. Brown, because these conditions do overlap, really. And I've pitched this talk to the most sort of common questions that I get asked in clinic. So I do apologize if it sounds simple, but I'm happy to discuss even more sort of complicated issues later on. So polycythemia vera is a myeloproliferative neoplasm of the bone marrow, where the bone marrow makes too many red blood cells. Apart from PV, we have ET, that's essential thrombocythemia, and primary myelofibrosis, which make up the MPNs. Now, it was about 70 years ago that an American physician, William Damschek, speculated really that these myeloproliferative disorders, as they were called, are manifestations of the proliferative activity of the bone marrow of perhaps undiscovered stimulus. And we know what that is today. Again, this is just a schematic representation of the bone marrow, and it is your red marrow, which makes your blood cells from a pluripotent stem cells, red blood cells, white blood cells, and platelets. And commonly seen in the lab, this is a blood film, the essential thrombocythemia. There's too many platelets. These are the dark purple dots. Polycythemia vera, too many red blood cells, and you can see how dark this is here, really, the hematocrit. Primary myelofibrosis, where the bone marrow, instead of becoming spongy, gets fibrosed. So Maz alluded to that as well, that it was called the MPN Voice, and these conditions were called myeloproliferative disorders. But in 2011, the WHO renamed them as myeloproliferative neoplasms. So is it a cancer? Yes, it is a form of neoplasm, a form of blood cancer, where there's uncontrolled or clonal proliferation of one type of cell. And we have discovered mutations which cause this. But it doesn't, it's reassuring that it doesn't behave as other cancers do, so it doesn't spread or metastasize. It is a chronic long-term condition which one can live with. It cannot be treated with surgery or radiotherapy. So how is it caused? So we have discovered a mutation, the JAK2 mutation, affecting the stem cells, which result in increased and uncontrolled proliferation of primarily red blood cells in the case of polycythemia vera, but also white blood cells and platelets. So the JAK2 mutation was discovered in early 2005 and described by 4 groups, but it was Wayne Checker who discovered it first. And in the UK, it was Professor Green's laboratory at Cambridge. I started my training in 2005 at Guy's and St. Thomas's Hospital under Professor Harrison. So obviously this was a very exciting time. and stimulated my interest in myeloproliferative neoplasms. This is a cartoon of the JAK2 mutation in polycythemia vera. So if you remember Dr. Brown's talk, it was the TPO receptor on the liver cells. This is the EPO receptor on the hematopoietic stem cells. So the JAK2 gene provides instructions for making a protein that promotes the growth and division or proliferation of cells. Now, this protein is part of a signaling pathway called the JAK-STAT pathway, and that's what it is. And this transmits signals from outside the cell to inside to the nucleus. So when there is a stimulus with the EPO receptor, this erythropoietin is secreted by the kidneys, which stimulates the bone marrow to make red blood cells. Red blood cells are produced, but there's an autoinhibitory mechanism. When you make enough, the pathway stops. Whereas when there is a mutation in the JAK-STAT pathway, it's a gain of function mutation. So it's as if you've turned a switch on and you've left it on, and it keeps producing red blood cells. So the most common mutation in the JAK2 is the point mutation, or where valine is substituted for phenylalanine. That's the V617F mutation, and that's found in 95% of cases. The other mutation in the JAK2 is the exon 12 mutation, which is found in 2 to 4% of cases. Patients with the JAK2 exon 12 tend to be younger with higher hemoglobin concentrations, but lower white blood cells and platelets. Dr. Brown's already covered this, and Professor Somervaille will too. The other mutations in MPNs, the CALR and MIPL, but just to emphasize that for polycythemia vera, it is the JAK2 mutations and not CALR or MIPL. So who does it affect? Again, very rare, 2 to 3 persons per 100,000. More common over the age of 60, but less than 10% of patients are under 40 years of age. And there is a slight male predominance. So what are the symptoms? Sometimes there's no symptoms at all. It's just picked up on a routine blood test. Whereas other times there are symptoms of hyperviscosity. So the thick blood leads to sluggish blood flow, and most common symptoms being headache, blurred vision, tinnitus or ringing in the ears. And unfortunately, some patients do present with blood clots, and mainly arterial in polycythemia vera. There are also symptoms of increased metabolism or just turnover of the blood cells because there's so many being produced. They get destroyed, waste products excrete in the kidney, and leads to increased uric acid and gout. And then you have the non-specific symptoms, and Louise has very eloquently described the pruritus or itching. Other symptoms, because of an enlarged spleen, could have abdominal discomfort or early satiety, fatigue, weight loss, sweats, erythromelalgia, this sort of the redness and coldness, heat, the tingling in the palms and in the feet. So how would you diagnose it? So very simple. On blood tests, you have increased number of red blood cells, the hematocrit or the thickness, and the hemoglobin. So more than 18.5 in men and more than 16.5 in women. Excuse me. In polycythemia vera, you can see the white blood cells and platelets are also raised. But because there's so much production of red blood cells, the serum erythropoietin is low. And the JAK2 mutation is present in nearly 100% of cases. And this helps us to differentiate as well between the primary polycythemia, which is a bone marrow condition, the polycythemia vera, versus secondary polycythemia due to smoking, excess alcohol intake, or again, erythropoietin secreting tumors. So the JAK2 the discovery of the JAK2 mutation was very important as well in distinguishing between primary and secondary polycythemia. So do you need a bone marrow biopsy? So it is not routinely done, because I said the JAK2 mutation is virtually present in most patients. But if the JAK2 mutation is negative, and there's still a strong suspicion of primary polycythemia, as in there is no clear secondary cause, or the serum erythropoietin level is normal or high, then you would do a bone marrow biopsy. Or if there are atypical features, so if there is marked splenomegaly, where you suspect that there may be myelofibrosis, again, you want to do a bone marrow biopsy to get a baseline view. Other investigations, always do a routine abdominal ultrasound as well to look at the size of the spleen, which may be enlarged. So, what are the complications? So, with thickened blood comes the complications of blood clots or thrombosis, and many patients do present with mini strokes or full-blown strokes, heart attacks, or DVTs, PEs, or venous thrombosis in rarer sites in abdominal blood vessels. Bleeding, mucocutaneous bleeding, the gums or nose or stomach. This is more rare and usually associated with people with polycythemia vera who have increased platelet counts and tend to get acquired bleeding disorders or platelet function disorders. So what is the prognosis? The prognosis is good, and I'd like to echo Louise here. It's a chronic long-term condition which you can live with. People can live for decades really, and all we need to do is to control the hematocrit. There is, however, a small risk of progression to myelofibrosis and a smaller risk to acute leukemia. And again, we monitor that very carefully in clinic so that we can pick that up early if it happens. So how do we manage polycythemia? So the aim of treatment would be to lower the risk of thrombosis and manage symptoms. And really, in the long term, what we would aim for is to decrease the risk of progression to myelofibrosis or AML. So lower risk of thrombosis, again, optimize all the cardiovascular risk factors, stop smoking, ideal body weight, regular exercise, control your blood pressure, diabetes, cholesterol, have yearly checks at the GP, and we send out a letter once a year, really reminding GP surgeries as well to perform these checks. Aspirin, the ECLAP study demonstrated there was increased survival benefit and decreased thrombosis in patients taking aspirin. Low dose aspirin, the dose varies in different countries. Here we use 75 milligrams once a day, but you can take anything from 75 to 80 to 100 milligrams once a day, unless it's contraindicated because of gastric ulceration or any other issue. Clopidogrel is another antiplatelet agent, and though it's not been used in trials, it would be an alternative to aspirin if you're intolerant of it. So the mainstay of treatment is venesection, and the aim is to decrease the hematocrit, which is the thickness of the blood, to less than 45% or less than 0.45. And this has been established as first-line treatment for polycythemia vera for a very long time. However, there are some patients who are unable to tolerate venesection, feel quite dizzy, can try replacing the pint of blood which is removed with an equal amount of normal saline. Sometimes venesections, especially if you need them repeatedly, may result in iron deficiency. But I would urge extreme caution with iron replacement. It has to be done under close supervision by a hematologist, as iron supplementation can cause the hemoglobin to overshoot the mark and increase your risk of thrombosis. So it has to be done very, very carefully. And then cytoreductive therapy. This is medication which is used to suppress the bone marrow from making too many blood cells. So similar to treatments in ET, hydroxycarbamide, interferon, pegylated interferon, anagrelide, and the older sort of chemotherapy drugs, busulfan, radioactive phosphorus, and then ruxolitinib. So it's very much a risk-adapted therapy. And again, we have to talk to the patient. We've got the clinical nurse specialist there, take a proper history, go through all the comorbidities. But in general, we focus on age and a history of thrombosis. So the age is variable. Some people put it at 60, some at 65, but this cutoff is chosen because at that sort of mark, 60, 65 years, not just for MPNs, but also other medical conditions, really, the cardiovascular risk factors are thought to be increased after the age of 60. So low risk if you're less than 60 and there is no history of previous blood clots. And then the mainstay of treatment is venesection to bring that hematocrit or thickness down, and correction of cardiovascular risk factors and low dose aspirin. Whereas patients are considered high risk if you're older. And again, I said because the cardiovascular risk factors increase with age, or you have a history of blood clots. And then we want to have more strict control of the hematocrit, so there's no variation or less variation. And so we opt for cytoreductive treatment, correction of cardiovascular risk factors similar to low risk patients, and aspirin with or without venesection. So the cytoreductive therapy is mainly for high-risk patients, but you can also consider it in low-risk patients, in those with progressive splenomegaly, because certain cytoreductive treatments help to shrink the spleen. And most recently, there has been a lot of papers published with the association of the white blood cell count and platelet count and the risk of thrombosis in patients with polycythemia vera. So we don't just focus on the red blood cells or hematocrit, but also consider the white blood cell count and the platelet count. So the white blood cell count, we'd consider it, the platelet count if it was greater than 15, and for the platelet count if it was greater than 1500. Cytoreductive therapy is also considered if you're not able to tolerate venesection, or the venesection is not controlling your hematocrit or thickness of the blood well. And again, also, but low risk patients, yes, say you're low risk, but sometimes people have uncontrolled or progressive disease related symptoms, whether it's, fevers, night sweats, the weight loss, extreme fatigue, the progressive itching, the uncontrollable itching. And again, then we may wish to consider cytoreductive treatment there. Okay. So hydroxycarbamide, we've been using this drug for decades, really. Is it a chemotherapy drug? Yes. Does it increase the risk of transformation to acute leukemia? So we know that there is a small risk of progressing to acute leukemia just with the nature of the blood cancer itself, ET, MF. There is no firm proof that hydroxycarbamide increases that risk. Is it well tolerated? So most patients will tolerate it well, but there is a small risk of skin lesions, mouth ulcers, leg ulcers, and really we do want to know if you are getting any of these symptoms, because any of these side effects, because we would want to review that drug really, or even pause it in more severe side effects. And some patients experience gastrointestinal side effects. Interferon. So interferon is, the normal interferon is an injection given 3 times a week. We would consider that for young patients who are less than 40 years of age, or those who are pregnant, because you don't want to give a chemotherapy drug there. However, there is quite a considerable side effect profile, and people tend to discontinue it because of flu-like symptoms, mood changes. It can also affect endocrine organs and cause other autoimmune disorders. Thyroid needs to be monitored. So pegylated interferon is a longer-acting interferon, is an improvement on interferon injections, can be given once a week like Pegasus, or once every 2 to 4 weeks like the Ropeg interferon. Now it is better tolerated, though patients do experience these symptoms, but it's much better tolerated than the regular interferon. I am going to mention these two trials, the PROUD PV and the continuation PV, where pegylated interferon alpha 2b, or the ROPEG interferon, was used really and compared versus standard therapy for polycythemia vera. So it was a randomized phase 3 trial. And the PROUD PV ran for 1 year, and then patients could continue on it for, and that was after 1 year. So it was an extension study. And really what they wanted to prove was non-inferiority to the standard, which was hydroxycarbamide, in terms of complete hematological responses or shrinkage of spleen. Now, it didn't show non-inferiority at 1 year, but on continued follow-up, and at interim analysis at 3 years, it did show that it had better results than hydroxycarbamide and was also well tolerated. Other cytoreductive therapy, anagrelide, which is used in ET, can also be considered, and in addition to hydroxycarbamide as well, or as an alternative to patients who have raised platelets along with raised hematocrit. And then the more old-fashioned drugs, or the chemotherapy drugs, really, busulfan, radioactive phosphorus, and the pipabromin, can be used cautiously in older patients, sort of smaller doses for those who are intolerant of hydroxycarbamide. Ruxolitinib. So many of you may have participated in the trials of ruxolitinib. So we know it's a JAK1 and JAK2 inhibitor. It was the RESPONSE trial, really, 2015. It was a randomized study which compared ruxolitinib versus the best available therapy in patients with polycythemia who were resistant to or intolerant of hydroxycarbamide. Now, it improved hematocrit control, definitely reduced the spleen size as well as the total symptom score when compared to the best available therapy, and also improved constitutional symptoms such as sweats, night sweats, and itching. This study did not target the endpoints like thrombosis, survival, and fibrotic or leukemic transformation. More recently, we've had the 5-year follow-up, which was published in the Lancet last year. And really that again is very promising because we've now got longer data, longer follow-up, probability of maintaining that composite response, and this is what I'm talking about, really was quite high, 75% nearly. And also found that the non-hematological side effects as well as the thromboembolic complications were lower in the ruxolitinib group. So the MAGIC trial, a number of patients from our centres participated in this, and this was a randomised control trial, again, comparing ruxolitinib with best available therapy in patients with high-risk PV and ET. The results for ET have been published, but the results for PV I'm not aware of yet. So I'm going to finish really with touching on the symptoms, because this is sometimes a neglected area in clinic. When we see our patients and we say, oh yes, your hematocrit's fine, continue with the venesection or continue with your hydroxycarbamide. But really what we've found more and more over the last 5 to 10 years is the burden of symptoms really which patients have. And I have to say, I work with a great team of clinical nurse specialists who are amazing at supporting patients through these symptoms. So this is, so you've probably seen this, which is the 10-item total symptom score with the various common symptoms in myeloproliferative neoplasms. And just to give you an overview, really, it's present in all 3 conditions, more so in myelofibrosis, and PV sits in the middle. The top 5 constitutional symptoms being fever, weight loss, itching, night sweats, and fatigue right up there, which is the most common. So Louise has you know, also already mentioned exercise does help with mood and symptoms really. We have an understanding with Salford Council, so patients are referred for an exercise program, have gym memberships when they're diagnosed with MPNs. Also, you know, talk to people about healthy lifestyle and diet, and the CNS run support groups. Again, just to mention, iron deficiency may be a cause of the fatigue, but correction of that should be done with extreme caution, as I've mentioned before. Again, Hdac inhibitors, ruxolitinib, has been shown to improve fatigue. So the management of itching or pruritus, so it is very common, seen up to 85% of patients can occur spontaneously, or as Louise has said, precipitated by water or sometimes changes in temperature. In use, both antihistamines, the H1 antagonists, like your standard antihistamines like cetrizine, Piriton, etc., but they're often ineffective. Consider adding the H2 antagonists as well, like ranitidine, for dual histamine blockade. Certain tricyclic antidepressants, as well as selective serotonin reuptake inhibitors, are also shown to be beneficial for the symptom of pruritus. We would consider cytoreductive therapy, even if you're low risk, and ruxolitinib again has also been shown to improve itching. Would consider referral to a dermatologist for phototherapy as well, for severe cases. So the MPN symptom burden is significant and worse than the general population. So if we looked at all these constitutional symptoms, this is the light grey line is where the general population sit, and the dark black line is where patients with MPNs, what they experience really. So the Measures trial did look at the symptoms of myeloproliferative neoplasms. Again, a number of you might have participated in this, keeping a diary really of symptoms. And really what would be analysed would be the various treatments you were on, and to see if that had any benefit to the symptoms. So we're still waiting the results for that. The Mithridate trial, that's ongoing, and that's comparing ruxolitinib versus hydroxycarbamide or interferon as first-line therapy, and this is in high-risk polycythemia vera. So again, it's a phase 3 randomized controlled trial in many centres. In Manchester, it's at Wythenshawe Hospital. We were looking to open this, but had been delayed because of COVID. So the future, venesection and aspirin remains the first-line therapy for low-risk PV, and just to reiterate that these are, very low-risk treatments with not many side effects. Cytoreductive treatment and aspirin remains the first-line therapy for high-risk PV, and in cytoreductive treatment, hydroxycarbamide is still the most widely prescribed treatment, though the recent studies really have established the safety and efficacy of pegylated interferon and ruxolitinib, so that is very encouraging. However, again, I do have to say that we've not had as much experience with these drugs in terms of long-term side effects as compared to hydroxycarbamide. The Hdac inhibitors, this is a long-term study of evaluating the effect of givinostat, and again, certain centres might have this open. And really, and what we do want to see as well with all these newer treatments and monitoring of the JAK2 allele burden is whether they decrease the fibrotic and leukemic transformation of polycythemia vera. So again, be very positive because it's very well treated really, and it can be managed really well. Okay, thank you.
That's brilliant. Thank you very much, Rowena. Extremely good talk and very clear slides. Thank you very much for that. Now we are running a little bit over time. So I'm going to hand straight over to Tim Somervaille. Tim, if there's anything that you can do to accelerate your talk, it would be much appreciated. We'd like to keep as much time as we can for our breakout groups. So without further ado, over to you, Tim.
Okay, thanks very much, John. Can everyone hear and see me?
I certainly can, thank you.
Right, okay, so fortunately, there's quite some overlap with what Rachel and Rowena have discussed with my talk. So you know, I'll be able to kind of not perhaps kind of dwell so much. So myelofibrosis is the third of the three myeloproliferative disorders that we're covering today. And so what is it? It's a type of fibrosis or scarring inside the marrow bone. And Rowena certainly showed a picture of the inside of the bone marrow. Just the same as the marrow bone you might get from the butcher. You know, the bone marrow is inside of the bones, inside of the ribs, inside of the skull bone. And in myelofibrosis, the normal kind of soft marrow becomes a little bit scarred. And this is just a microscope picture showing some of those strands of scarring and fibrosis within the marrow. What it does is it pushes the normal bone marrow cells out of the bone marrow and into the spleen and the liver, and so the liver and the spleen can get larger. And this myelofibrosis, it may appear by itself when it's called primary, or of course it may on occasion evolve out of polycythemia vera or essential thrombocythemia. And as Rachel said in her early in her talk, these are the megakaryocytes, the big cells, and here they are cuddling together. They're not supposed to do that. And so in myelofibrosis, in addition to the scar tissue, you have too many of these platelet forming cells called megakaryocytes, and as Rachel said, mega for big. And these cells seem to make chemicals which cause the bone marrow scarring. But fundamentally, this is a rare disease, and it mostly presents well over the age of 50. And as Rowena and Rachel have mentioned, there's a good frequency of this JAK2 mutation. Perhaps half of patients have a JAK2 mutation in myelofibrosis. Many of the rest will have this calreticulin mutation. There's also the MPL mutation that makes Rachel chuckle, as well as a number of other mutations which have in recent years been noted, which sometimes crop up with these main three. As I've said, it usually develops slowly, and many people with myelofibrosis might live symptom-free for a number of years. However, of course, many people with myelofibrosis do experience some symptoms, and often those symptoms can be really troublesome and really, for some people, can impair quality of life quite significantly. Louise mentioned the fatigue that is frequent in polycythemia vera, and also all of the myeloproliferative disorders. And fatigue and tiredness is also a prominent feature of myelofibrosis. People will sometimes have symptoms of anemia, so the red cell count is low, and so you might be out of breath or just puffed out. When the spleen is enlarged, that can cause discomfort or even pain. And then going down to the bottom of the list, because the spleen can rest on the stomach, it can make people feel full part way through a meal because the spleen is pressing on the stomach. And that in turn can lead to weight loss because you're not getting enough calories in. And then in addition, some people with myelofibrosis might have sweats at night. They might even have a fever, an increased risk of infections, some bone pain, the pruritus, the itching that Louise mentioned, which is a feature of polycythemia vera, but of course it's also a feature of myelofibrosis as well. So there is a real range of symptoms that people can experience with myelofibrosis, ranging from nothing at all through to really quite profound assess a really quite profound set of symptoms which can really impact on quality of life. So when people go to see the doctor with a suspected diagnosis of myelofibrosis, what tests to get done? So of course it's the routine blood test. So in myelofibrosis, if you suspect myelofibrosis, a bone marrow test is pretty much essential, really, to have a look in the marrow and document that scar tissue, but also to see what else is going on with mutations and so on and so forth. Looking down the microscope, you might see these red blood cells that look a little bit like teardrops. So a normal red blood cell down the microscope would look round like that. But where you have these oddly shaped red blood cells that look like a teardrop, that's quite a characteristic feature of myelofibrosis. So what are the treatments? What are the treatments for myelofibrosis? And when I meet a new patient with myelofibrosis, the first question that we always have to consider is this patient sat in front of me suitable for a bone marrow transplant? And the reason we ask that is because there is a chance with a bone marrow transplant that you can cure myelofibrosis. But that comes with it a significant risk of serious and even life-threatening complications. So a bone marrow transplant for myelofibrosis is never to be undertaken lightly, and it would always involve someone being extremely fit and well without any other serious problems with their health. And I have to say, in our practice, once you kind of head past your mid-60s, the benefits of a transplant tend to get outweighed or at least matched by the risks associated with a transplant. So that's a very serious and careful decision that needs to be taken for transplantation in myelofibrosis. So if the individual is not suited for a bone marrow transplant, or even if they are potentially suitable for a transplant in the future, but nevertheless need treatment now, what we try to do is to tailor the treatment to the individual patient's needs and symptoms. And the goal here is the best quality of life and the maximum length of life. So here are some of the treatments that we might consider in myelofibrosis. And there's a mixture of blue treatments and red treatments here. And the red treatments are the ones that are coming down the tracks, and I expect will be available if not next year or the year after, but they're coming, and I'll explain why shortly. But the way to approach a person with myelofibrosis who needs treatment is to have a think about what type of problem is the main problem for the person in front of you. So some people might just have anemia, and that's making them feel a bit out of breath, a bit tired. And so if you improve the anemia, then they may well feel better. So some of the treatments we might consider are EPO. That's the hormone that the cyclists inject into themselves illegally so that they can cycle up the mountains more rapidly. The reason why they do that is because it bumps up your red blood cell count. And so if you have a normal red blood cell count and you take EPO and that goes too high, that can cause problems with heart attacks and strokes. And that's why it's banned for the cyclists. Of course, there's ethical reasons. But if your hemoglobin is low, under medical supervision, this EPO treatment, stands for erythropoietin, will hopefully push up your blood count towards the normal range and then reduce some of the symptoms. Of course, EPO only works for some people, and so under those circumstances, there are other treatments such as danazol, another treatment called thalidomide, which is often given with steroids, something called prednisolone. And these are effective treatments for some, but perhaps only 1 person in 3 might respond to them. And then, of course, if all else fails, there's blood transfusions, which can keep people well and give them a good quality of life, albeit at the expense of having to come into hospital, once a fortnight or once a month to have the treatment. As I say, coming down the tracks is this newer treatment called luspatercept, which seems to increase the red blood cell count through a different mechanism. And you can look that up on Google if you like, but it's not quite ready yet. So if you have a big spleen, which is the main problem, something which is kind of bulky, perhaps resting on the stomach, but otherwise not causing particular problems as far as sweats and weight loss are concerned, then hydroxycarbamide can be a good treatment for that. Interferon can sometimes be helpful. And then, as Rowena mentioned, some of these older fashioned treatments might be considered, perhaps less frequently these days, but busulfan is one of them. You can even take the spleen out, which can be beneficial for a small number of patients. And then there's also the possibility of having splenic radiotherapy. So that's having a bit of radiotherapy to the spleen. But again, that should be very carefully considered because it can sometimes cause just as many problems as it solves. And then moving on to medicines for night sweats, itch, and weight loss. Well, what's really changed things over the last 8 to 10 years here is ruxolitinib, which really does both increase quality of life for a significant proportion of patients, as well as increase the length of life as well. Coming down the tracks is this newer drug fedratinib, which has already been approved in the US. I expect it will get approved in the UK in the next couple of years. So that's sometimes effective when ruxolitinib doesn't work so well. And then also navitoclax and pelabresib, and I'll just touch on those at the end of my talk, are 2 more drugs that seem to have additional benefit when they're added into ruxolitinib in these in clinical trials. So we always so we have some treatments which are helpful in improving quality of life and length of life, but we always need better treatments, and of course that needs research. And Maz and Jon and others have touched on the need for research in their introductory words. And I'm just going to just whiz through how it is that we have the treatments now that we didn't have previously. And in essence, all new medicines for patients come through this process of clinical trial development. And these treatments will start out in the laboratory. So scientists and doctors working hand in hand in the laboratory, thinking about how the disease works and how the disease develops, such that they can think of new approaches, new strategies to develop. And so these laboratories might identify a new molecule, a new drug, which then moves into a succession of clinical trials. First of all, involving tens, that's phase 1, and then hundreds, phase 2, and then perhaps thousands over phase 3. And through that process of safety testing and efficacy testing, so that means checking that the drug does what you hope it does in a patient population, and hopefully does it better than the best existing treatment. So that process of phase 1 to phase 2 to phase 3 trials might take perhaps 6 to 8 years. And so this slide just says that's what I've just said again. So phase 1 studies are asking, what is the most effective dose, and is the drug safe? Safe is always critically important when we develop new drugs. Then phase 2 studies, how active is the drug in treating patients? And again, these are typically fairly small scale studies. And then that moves on to a phase 3 study to compare a new treatment with the best treatment currently available. And that can sometimes be randomized, or more typically is randomized. And sometimes it's what we call double blind, where neither the doctor nor the patient knows which treatment they're taking. And this is just an example of the development of ruxolitinib for myelofibrosis. This JAK2 mutation was first discovered back in 2005, and 4 years later, the phase 3 studies for ruxolitinib were already starting. And some of you may be familiar that these trials were called Comfort 1 and Comfort 2, and one was in the US and one was in Europe. And these studies completed fairly quickly. And because ruxolitinib was shown to be so effective in those studies, it was approved by the United States Food and Drug Administration in November 2011. And then those results were published in 2012. And that's what the chemical structure of ruxolitinib looks like for all of the chemists in the audience amongst you. So this is what ruxolitinib delivers. So it's not necessarily for everyone, but for many patients with myelofibrosis. So here's someone with a big old spleen, and another important thing to say here is that they've got, you know, these kind of gullies between the ribs. So this is someone who's lost flesh weight and has got a big old spleen because that spleen's pressing on the stomach and they're not eating properly. And so this individual, this man, has got on to ruxolitinib, and here you can see 12 weeks later, the spleen has shrunk, but also importantly, you can see that he's put on some flesh weight, which is good news for quality of life. And these are the imaging studies showing a reduction in size of the spleen from big to smaller here. Now, these are graphs which show all of the patients. So each bar shows one patient, and all of these bars together show all of the patients in the US and Europe. And it shows how they responded to the ruxolitinib treatment. And so you can see that the great majority of patients going on ruxolitinib had at least some shrinkage of their spleen size on treatment. And here are the symptoms. And so, you know, I often think that you know, so many patients will feel a bit better with their spleen being a bit smaller, but actually many patients with the myelofibrosis, their spleen isn't so much the problem, it's their symptoms. It's that, you know, they feel exhausted, they have, you know, they have sweats, they have itching, and ruxolitinib is great treatment in particular for patients who have weight loss, sweats, and itching with their myelofibrosis. And what these bar graphs all show is that the patients in one of the comfort studies who where it was randomized between the ruxolitinib and a dummy treatment, the placebo, the patients on the placebo got worse, whereas the patients on the ruxolitinib, their symptoms all improved. So the green bars are getting better, the symptoms, the blue bars are their symptoms getting worse. So ruxolitinib makes people feel better, and also as an outcome from the original comfort studies, it also shows that patients live longer on ruxolitinib. So that was great news, even though those studies were not really geared to reveal a survival benefit. So that was great news. But now other JAK inhibitors are in the pipeline. Some of you may be aware of other drugs which I won't mention. They've slightly fallen by the wayside in the clinical development, but I think the one that really has come through is this drug called fedratinib. As I say, it's already been approved in the US by the Food and Drug Administration. And so this may be useful for some patients when ruxolitinib has stopped working. And then other drugs, other types of drugs. So these aren't JAK inhibitors. These are other types of drug are also in the pipeline. And so one of them is called navitoclax. For those of you, those aficionados amongst the audience, it's a BH3 domain inhibitor, but this seems to work by helping to kill off some of the myelofibrosis cells, and the clinical trial results of this with ruxolitinib. So they're both added into the treatment regime together. It seems to be better together than either one alone. So those results are shortlisted to be published, and a big phase 3 study internationally is now underway. And there's another drug called pelabresib. Again, this is a different class of drug, a different type of drug. It's called a bromodomain inhibitor, and this also reduces the growth of myelofibrosis cells. And again, the clinical studies show that when it's added in with ruxolitinib, it seems to be better than either of them on their own. So again, the trial results are shortly to be published, and a major international phase 3 is underway to see whether this will, both of these drugs, to see whether both of these drugs will end up in our formulary so that we can prescribe them to patients in the years ahead. So to summarize here, basic science research leads to new treatment targets, leads to drug development, and then into clinical trials. And of course, over the years, things are a lot better now than they were, but there's still a lot more for us to achieve for our patients. So thank you. And I think now we're ready to move into the question and answer session, but I don't want to steal your thunder, Jon. So.
Thank you, Tim. Brilliant. I'm always very pleased when I see a presentation from a hematologist that includes the name of a drug I haven't heard of before. It shows how much work's going on. So that pelabresib looks
impressive. Yeah,
fantastic. Okay, you're absolutely right. This is the Q&A part. Just for everybody's information, because we're running over time a bit, we're going to reduce the time that we have available right now for Q&A. So the plan is that we will run the Q&A until about 6:05. We're going to reduce the comfort break time by 5 minutes, and then we'll plan to come back from the comfort break at 10:10. So if you're desperate for the loo, just hang on until 6:05. And then I'll explain what we're going to do then. So I think, Tim, you wanted to start with a few things about COVID to start off with. Lots of people had asked questions about that.
So in the questions that people submitted when they registered, it was very clear to us that maybe about a third of the questions were focused on vaccines and their activity. So I just wanted to, if you like, preempt those questions, or hopefully I'll answer a whole load of participants' questions all in one go. And so, as the words of Blue Peter, here's one I prepared earlier. So I think this is a question which just came up again and again in the submitted questions, and rightly so. So I'm going to answer that question with data from, sorry, I mean, I do apologize. It is quite a text-dense slide, so I apologize for that. But I just wanted to summarize for you data, information that was just published recently from a group of researchers in Oxford, led by Dr Bethan Psaila. And I think the main thing to say is that we're still short of information on vaccine activity in MPN patients. But this study is a good first start. And I would also say that there's a lot of activity, a lot of research going on at the moment. And so as each month goes by, there's going to be more information for you. But as I say, this study, which has just been published, looked at 29 MPN patients, and 16 of them were on treatment. And to summarize, 2 weeks after one dose of the Pfizer vaccine or the AstraZeneca vaccine, around half of patients developed an antibody response compared to nearly all of healthy adults. So there is clearly a chance that if you are an MPN patient and you've had a vaccine, your antibody levels after the first dose may be lower than someone else of the same age who didn't have an MPN. And so when you look at the disease by type, it looks like ET patients well, it's low numbers, but if you look at ET patients and MF patients and PV patients, really it's about 50-50 in terms of having an antibody response to the first dose. Importantly, there was no difference in this limited study according to which vaccine was given, Pfizer or AstraZeneca. Okay, so for people with an MPN, the treatment type does seem to be linked to the antibody response. So, for example, 88% of ET patients on interferon had antibodies. 36% of people on hydroxycarbamide had antibodies. However, people on ruxolitinib didn't seem to develop antibodies, okay? And this included 1 ET patient, 2 PV patients, and 2 MF patients. But I can't emphasize enough that the numbers here are very small, okay? And the data are still, you know, very early days. So the conclusions here really are that MPN patients who aren't on treatment can produce antibodies, although not everyone does. MPN patients who are on treatment can also produce antibodies, although not everybody does. There's no difference in effectiveness between Pfizer and AstraZeneca vaccines. For people with MPN, the treatment that you're on could make a difference to the vaccine response. But there's still so much we don't know, okay? This study only looked at response after 1 vaccine dose. And of course, everyone's had 2 vaccine doses. So it's highly likely that the antibody levels will be much higher in patients who've had 2 doses rather than 1. Another really important thing is that your immunity against COVID is not just from antibodies. There's also T cells. And this study only looked at antibodies and not T cell responses. So people are looking elsewhere at T cell responses, and those could be important to protect people. People in this study were aged between 50 and 70, so we don't know what the responses are in younger people. And again, I can't emphasize this enough, this is a small number of patients, so it only gives an indication and not a firm conclusion. And so until more monitoring is done, we don't know how much this is, maybe I should just re-emphasize, until more monitoring is done, we don't know how much the reduced antibody levels that seem to be present will impact on COVID infection risk and rate, because no one quite knows what levels your antibody have to be to protect you against serious illness or even death from COVID infection. So it may be that even though the antibodies are lower, that people are still being protected. So another really important thing to emphasize is that you're protected not just by the vaccination that you've had, but also by being surrounded by people who have been vaccinated, because of course vaccinated people are much less likely to pick up the virus and to pass it on if your antibody levels are not so high. So I hope that answers some of the questions that that came through in the pre-talk sheets that we had.
Thank you, Tim. I'm sure it does. So were there other questions that you had looked at prior to the meeting that you'd like to address now, or maybe some of the other doctors would like to address some of those questions? I don't have a particular one in mind, but
shall I just kind of whiz down the list here? So sure. Rachel, so one of the questions was when should we have a bone marrow biopsy? Some suggest this should be done as part of a diagnosis. Others suggest it's not important. I'm confused! !
And yeah, it's a lot of haematologists are as well. So you don't need a bone marrow to be diagnosed with ET or PV in the majority of cases, because we've got those lovely molecular markers we can get on the blood. Obviously, myelofibrosis is different. You definitely need a bone marrow for that one, I'm afraid. It would be good practice to do a bone marrow on everyone at diagnosis, just so we've got a baseline. And if, you know, a bone marrow didn't hurt and was like having a blood test, then we probably would do them on everyone. But they are slightly uncomfortable, and as I say, not the most fun you can have. And also during COVID, you know, times, we've now got to think about how appropriate it is to bring patients to the hospital for tests to sit on our day unit and mix with other patients if it's not going to change your management. So I don't do it routinely. Although, as I say, pathologists would love you to all have a bone marrow, because they love looking at bone marrows and trying to find out the really, you know, weird and wonderful things. I think if you're a straightforward patient, then a bone marrow isn't necessary. But I generally have a chat with the patient and say, look, you can have a bone marrow just to confirm the diagnosis and go through the pros and cons of that, but I don't think it's going to change your management. And to me, I only really do a test if it's going to change my management of a patient, because otherwise, what are we doing it for? I don't know if both of you would agree with that.
I agree. Yeah. So I'm going to follow that up, Rachel, by asking you a question from Robert Butchart, who wanted to know, is there a hereditary component to ET, PV or myelofibrosis? What would you say to that, Rachel?
So in the majority of cases, absolutely not. I think, you know, there are some case reports of some hereditary JAK2 mutations. I have one chap from Greece in my clinic out of the probably 250 patients I have with MPNs. The majority of cases it isn't. This is an acquired condition. But we all have genetics that make us slightly more prone to to certain things than others. So, you know, unfortunately, my mother has big hips, so I was prone to get big hips as well. And in the same way, you know, your family may have something that makes you slightly more prone to getting the JAK2 or the CALR mutation. So there can be, in some patients, kind of, you know, a couple of family members that have similar conditions. But in the majority of cases, no, it's not hereditary, it's not genetic, it's not something that you're going to pass on to your children, and is an acquired mutation. And unfortunately, the people that get it are just unlucky.
So Rowena, I'm going to ask you, is there any evidence that longevity is prolonged with hydroxycarbamide versus venesection? So I guess this is a question about, you know, what is the value of hydroxycarbamide versus venesection alone?
So I don't know of any sort of direct evidence, and I'll open it up to both of you as well. But I think that the treatment of the disease, so if it is well managed, so if your polycythemia is well managed, then obviously that will translate into less complications, less symptoms, and increased longevity. So venesection's a low risk option, but for some patients it doesn't work. And you know, where you have the seesawing up and down of the hematocrit, and when patients have had thrombosis or even, you know, a lot of cardiovascular risk factors, then you do want to have a more stable, controlled hematocrit, and that's when we go for the cytoreductive treatment. So I don't think cytoreductive treatment is undertaken lightly as well, because hydroxycarbamide is a chemotherapy drug, and yes, venesection is a very low risk treatment. But it's when, you know, when the hematocrit is not well controlled, then we would go towards the cytoreductive treatment. So I don't know, Tim, do you know of any study in particular reporting that?
It's not so much longevity, but we of course know that for higher risk patients, that hydroxycarbamide reduces the risk of strokes and myocardial infarctions, and of course, suffering one of those is accompanied often with a significant impairment of quality of life. So, so I think that's an important thing to say. And related to that, someone had asked, is there a lactose-free form of hydroxycarbamide? And well, to whomever answered that, asked that question ahead of the meeting, there are two preparations which are lactose-free. There's an oral solution of hydroxycarbamide under the brand name of XROMI, Xromi, and then there's also another one called Cyclos, which is a tablet form. But those have been prepared with patients with sickle cell anemia in mind. So it might take a little bit of persuasion, but fundamentally there is a lactose-free preparation, and if that were an issue for you, you could discuss with your hematologist regarding that. So I'm now just whizzing. Is any progress being made in reversing fibrosis of the bone marrow? So I guess I could just speak to that about it. So it's an active area of ongoing research. What we would typically say is that for someone with myelofibrosis, a treatment like ruxolitinib, we wouldn't say that would reverse the fibrosis. But there is some preliminary evidence coming through from these newer treatments, navitoclax and the pelabresib, that there may be some reversal of fibrosis or some reduction of fibrosis in some patients. It's a very active area of research. So I think the thing to say there is watch this space. Rachel, another question here. Has the percentage? Sorry, it's quick fire questions. There's 50 in my sheet here, so I think we've only got 10 minutes. Is it? Is
another 5 minutes. Tim.
Another 5 minutes. Okay, fine. Rachel, quick fire answers. Has the percentage or the risk element changed for having a bone marrow transplant for myelofibrosis?
I mean, you'll probably know better than I, so I am not a transplanter, but I think it has, because we've got drugs like ruxolitinib and all the exciting drugs that you were talking about. Bone marrow transplants are not for the faint-hearted. I don't think any of us are particularly hard gun transplanters here. So yes, I think we're probably less likely to do them when we were 10-15 years ago, because we've got better treatment options for myelofibrosis, and you've got to compare the pros and cons. That's not to say that transplant doesn't have its place for some patients. Sorry, that wasn't very quick fire.
No, that's perfect. Another question from Robert Butchart. Can you describe a classic type of patient with myelofibrosis who would decide to go for a transplant? I would say that would be someone who would be, otherwise fit and well, with myelofibrosis that is beginning to cause significant issues with their health, impairing their quality of life, and maybe they might be in their late 50s, perhaps early 60s, with no other health problems. That's someone who I think would be a so-called classic person you'd recommend for transplantation. Now, there's a few questions about Besrami. Rowena, do you want? So someone said, is Besrami likely to be licensed in England? Other people were asking about Besrami and interferon in general as a treatment in polycythemia vera. Do you want to speak?
Yeah, so I did speak a little bit about it on my presentation, really, and also with treatments in the future. So I think it's very good data, and it's at least we've gone up to 3 years, 5 years on the pegylated interferon and ruxolitinib. And in particular for pegylated interferon, the trials with complete hematological responses, which were sustained at 3 years, and also the molecular responses. So I think when we look forward with these conditions, you know, decreasing the JAK allele burden, going into remission, is this going to translate into increased overall survival and decreased transformation to myelofibrosis and leukemia? But I think it's still early days. So for someone who is high risk and well established on hydroxycarbamide, I think I saw one of those questions came in today, I wouldn't be changing treatment, but certainly for younger patients, and you know, where you talk through the different treatments, it's definitely an option. Where we are in the UK, I don't think we can, it's you know, that freely available. It depends on where you are. So again, for younger patients, for pregnant patients, we can access it. Or if you have PV or ET with a degree of myelofibrosis, again, you know, we can put in applications and access it. But it's still not freely available. It's more on where you are based in the UK.
Rachel, some questions for you on ET and the menopause. How can you tell if your symptoms are from ET or the menopause? And then related to that, what is the situation for people with ET and PV who would benefit from hormone replacement therapy?
Sorry to interrupt. Can we make this the last question before the breakout? Yeah.
So it's a really good question about the symptoms, because the symptoms of ET can often be quite non-specific, and there is some overlap with menopause, and often it's, you know, if the symptoms get better with an aspirin, or if you start cytoreductive treatment, then it's probably the ET or the PV, and if it doesn't, then it's then it may well be the menopause. It can be just a little bit of trial and error, really, sometimes in those situations, but also how long you've had it for, you know, what the platelet count is and things. The second question, sorry, was situation with HRT and ET with hydroxycarbamide. So having hydroxycarbamide doesn't stop you from having HRT. It's actually you having ET or the PV, which puts you at that higher risk of thrombosis or blood clots, as does some HRTs, particularly oral estrogen HRT. So as I say, if you need a progesterone only HRT, which is generally ladies who've had their, you know, hysterectomies and their ovaries removed, then that's absolutely fine. That doesn't increase your blood clot risk. Topical treatments, so your patches, your creams, your pessaries, they're absolutely fine to have. And then after that, it is, you know, a look at the you know, the benefits and cons of HRT. If you're very, very high risk of blood clots, if you've had a blood clot in the past, then I'm probably going to say that, you know, we might need to manage your menopause symptoms in other ways if we can. But at the end of the day, I think as sorry, Tim, as there are more and more female doctors around and less men who I'm sure are not as sympathetic as Tim. I'm sure Tim is very sympathetic towards ladies. You know, I do think that GPs need to be, and other doctors need to be more considerate about ladies with the menopause, because it's not just something that we all should go through. But that's my equality hat down. Sorry.
That's brilliant. Thank you, Rachel. Well, welcome back, everybody. I can see that we've got nearly as many participants now as we had when we started. So that's fantastic. Thank you for putting up the last slide, Danny. I'm sure that's you doing that. So we had an extremely productive, I would say, interesting discussion in the breakout group I was in. Really enjoyed hearing from other patients. As usual, even though we've been connected for the last 3 hours, it always seems too short, and I'm sure many of us have thought of questions that we have been wanting to ask and haven't had the chance. On that subject, what I would say is, if your question hasn't been addressed so far this evening, what I would say is that we will attempt to answer all the questions that were submitted in advance of the forum and during the course of it. by email subsequently. And please don't hesitate to get in touch with Maz through the MPN website, info@mpnvoice.co.uk, .co.uk, org.uk, I can't remember, it's on the website. If you haven't had your question answered in the next few days, we'd be happy to pass that on to whoever's best equipped to answer it. And we will do our best to answer those questions. So the other thing that I saw a question on earlier was about the slides. So what I would say on that is that, as you probably are aware, the whole of the presentation, including all the slides that the doctors presented to us, are available on the recording, which and a link to that recording will be published on the website, but also on our social media channels in the next day or two. So if there was anything that you thought you might have missed, or maybe you had to pop out for a moment and wanted to look back at anything that anybody said or presented, have a look back at the recording, and of course you can then pause it at that point and make a note of anything that you'd be particularly interested in or wanted to answer a question about. So that pretty much brings us to the end for today. On behalf of MPN Voice, I'd really like to thank all the doctors from the Northwest, from Manchester. I think it's been a fantastic set of presentations. I'd also like to thank everybody who's joined us this evening. I think it's been a really amazing turnout. Well done, and thanks to everybody. And then lastly to Danny at Guy's and St Thomas's, who's done an amazing job of putting the whole thing together from a technical point of view. I apologize again for the technical meltdown I had at the very beginning. And of course, thanks to Maz for picking up the pieces when that happened. So thanks again. With that in mind, I'd like to thank everybody again, and look forward to seeing you all in person, hopefully before too long, and stay safe. Bye for now.